All right, thank you. Thank you for being here tonight. I'm glad to have this kickoff discussion for this year's American Dream Conference. Thank you, panelists, for being here. It is no secret that healthcare in America has been shaped by a number of influences that have made the delivery of healthcare very difficult for many people to understand, including me at times. Advances in technology, growth in various payment models, and policy changes, among other things, have all made this very difficult for consumers. The average consumer just wants to know, how do I get it and at what price? My colleague, Dr. Stephanie Vomvouras, and Professor Lawrence Brown and Professor Guian McKee would join Melissa Hogan in a conversation that will shed light on how American healthcare got here and where we go from here. Please, welcome the panelists.
Thank you, and welcome to our panel discussion, The Historical Oddity of American Healthcare. We're here to explore post-World War II history of American health policy. And before we begin, I'd like to recognize and thank BlueCross BlueShield of Illinois for sponsoring this session and for our American Dream Reconsidered Conference for the third year. And also to our alumnus and trustee, Maurice Smith, for his continued support. I'm pleased to welcome our three panelists who bring a tremendous amount of expertise in U.S. health policy development. Dr. Lawrence Brown is a professor in the Department of Health Policy and Management at Columbia University's Mailman School of Public Health. He's the author of Politics and Healthcare Organizations, HMOs as Federal Policy, and of articles on the political dimensions of community cost containment, expansion of coverage for the uninsured, national health reform, and cross-national health policy. Please join me in welcoming Dr. Brown. Dr. Guian McKee is an associate professor in presidential studies at the University of Virginia's Miller Center of Public Affairs. He's the author of The Problem of Jobs, Liberalism, Race, and Deindustrialization in Philadelphia. His research focuses on how federal policy plays out at the local level in American communities, and he is currently working on a book that examines the rise of the healthcare economy in American cities after World War II. Please join me in welcoming Dr. McKee. And Dr. Stephanie Vomvouras is Vice President and CMO of Quality and Accreditation, Healthcare Service Corporation at BlueCross BlueShield of Illinois. She is a board-certified internal medicine physician and has presented and published work in peer-reviewed journals. She is a fellow in the American College of Physicians and a member of the National Quality Forum. Dr. Vomvouras served as Community Health's All In Chicago 2017 committee chairperson. Please welcome Dr. Vomvouras. So before we begin, I'll provide a very brief historical framework for the discussion that will follow. It seems that not a day goes by in which something about national health care policy is in the headlines. Much of our current political discourse and disagreements are focused on whether or not the Affordable Care Act should be dismantled. This law was passed in 2010, and it was designed to increase health coverage and access to a large portion of the population, to reduce growth in spending and improve outcomes. But before we can effectively consider the merits of this legislation and the best path forward, it's useful to first understand where the Affordable Care Act falls in the progression of health policy over the decades. These policies that have developed over the past 75 years reflect our wide-ranging national values of competition, innovation, regulatory restraint, individual liberty, and social justice. As Dr. Brown summarized in his book, U.S. health policy can be understood in the framework of four general strategies: subsidies, financing, reorganization, and regulation. Prior to World War II, government intervention in healthcare was limited to financial support of public health efforts. Following the war, the first initiative, subsidies for certain healthcare-related efforts, was adopted. These include subsidies for biomedical research funded by the National Institutes of Health, planning and constructing of new hospitals, and support for the training of physicians. The next major initiative of financing of healthcare began with the 1965 Medicare and Medicaid program. As described by Dr. McKee in his 2017 article, Prescription for Success, the passage of this legislation represents a significant political accomplishment for President Johnson's Great Society. This legislation was first introduced by Kennedy and underwent significant opposition from the American Medical Association and Republicans, who warned it was the first step to socialized medicine. These programs entitle elderly, poor, and disabled to federal funds to pay a portion of their medical bills. Rapidly increasing costs became a major consequence of these programs and were the impetus for the next two initiatives. The HMO program was started in 1970 and represents an attempt at reorganization of healthcare delivery and reimbursement. This program sought to use incentives away from fee-for-service models toward capitated programs focused on outcomes. At about the same time, regulations were developed to also rein in costs. For example, programs were developed to monitor appropriateness of hospital admissions and lengths of stay, as well as the requirement of state boards to limit the expansion of hospital facilities and equipment. The Affordable Care Act comprises several of these initiatives, including financing to expand care to more individuals, reorganization in the form of accountable care organizations, and regulations regarding key provisions in health plans. Notably, rising healthcare costs continue to be a significant issue in American health policy. So it is within this historical context that third-party payers, healthcare providers, healthcare organizations, and individual consumers of healthcare find ourselves. We'll now turn to our panelists to help us understand the politics and policies that have shaped U.S. healthcare in the U.S. and to give us a more nuanced perspective of the opportunities and challenges for the U.S. healthcare system. So we'll start with a closer look at the history of this U.S. health policy. So were there any moments that you can see of missed opportunity that might have allowed everything to be different?
Well, I'll take a quick shot at it and hear what my colleagues have to say. If you mean everything different, I mean, when you ask that question, to me that connotes, could we have at some point achieved affordable universal coverage or national health insurance, everybody covered on reasonably uniform terms and some kind of constraints on costs. I can see 2 episodes before the Obamacare episode. I mean, the big changes in our system tend to occur atypically when an election produces unusually liberal Democratic presidents with an unusually high degree of liberal Democratic support in both houses of the Congress. And such an election was 1932, which brought in Franklin Roosevelt in the middle of the Depression. And some of you probably don't know this history. There was a lot of hope on the part of New Dealers that we're going to do not only Social Security and unemployment compensation and the like, but national health insurance. But Roosevelt, for various reasons, decided not to push it. He thought it was too politically risky. Second such episode, the election of 1964 brought in Lyndon Johnson in a landslide with a lot of new liberal Democratic members of the House and Senate. And there's still people around today who advised Johnson at the time, what might have been if only we had had a bolder, broader vision and tried to go for something more than just Medicare and Medicaid. And then by the time you get to 2008, again, you got an unusual election in the middle of the recession. And you're able to achieve the Affordable Care Act, but you really couldn't have done too much more, in part because since the 1970s, and particularly since Medicare and Medicaid were enacted, you look at those statistics. Do you trust the federal government to do the right thing all the time or some of the time? It's just plummeted from like 70% to 14% or something like that. So what might have been, one can look back, but it's very difficult in the American context to do the kinds of things we associate with a European welfare state. But I'm not the historian, Guian is.
You've done well. Those are both I think, key opportunities that, it didn't happen. I'll add another period, which is essentially the mid-1970s, not a time we usually think of as a great moment of opportunity for expanding the American welfare state or growth in social programs generally, but there are a couple of unique factors. Ted Kennedy had been pushing since the late 60s for a universal healthcare program, the initial plan, one that really was true national health insurance. As you moved into the Watergate period, to make a long story short, Richard Nixon was under tremendous pressure to prove that he was still relevant, and he made significant compromises with Kennedy, and there were moments at that point where had the Democrats been willing to, and some of their constituencies, been willing to take that compromise, we could have moved to something that would have been much more expansive than the ACA would actually have been. It would have included some of the same elements. It wasn't what Kennedy had been pushing in 1969. The usual story is that ends with Watergate, with the decline of, or the fall of Wilbur Mills, who was the powerful chairman of the House Ways and Means Committee, who got involved with in an affair, a very public affair, with a dancer, put it that way.
Nicely said.
And they ended up in the tidal basin. That's a long story. It means Mills had to resign, and no one else was really able to do the deal. I think the opportunity actually did continue, though, into the Carter administration, at least its very early years. The reason I think that is one of the keys to making any universal coverage program work over the long term is to attain cost control. And at that moment, in the mid-70s, the early Carter administration, some of the first steps towards hospital cost containment were very much on the table. Carter tried a very simple plan. Kennedy was pushing, again, for a universal coverage plan. They couldn't come together. There were better plans in the Senate. If Carter had moved with the Senate plans, they could have reached a deal with Kennedy. Variety of complicated reasons it didn't happen, but I see that period from about 1973 to maybe 78 as one of the moments where we could have come up with something that was actually, if not national health insurance, would have been significantly more progressive than the ACA as eventually passed.
So within that framework of those historical opportunities or missed opportunities, can you comment on where the Affordable Care Act or Obamacare fits into this historical trajectory?
I see the period really from 1969 to the passage of the ACA as a process of gradual narrowing of options, of pressures from cost first, pushing Kennedy to move from an initial proposal that literally had no cost sharing, no copays, no deductibles, to the point, as I mentioned, by the late 70s, he was willing to accept not only cost sharing, but significant steps towards hospital cost control. A movement then in the 80s towards more market-based solutions, ideas like mandates, that initially emerged with Nixon on the employer side. By the early 90s, that's added to the individual mandate emerges out of conservative think tanks. And what you see is a movement over time away from that kind of pure ideal of national health insurance to more steps to control cost, to bring consumers in to some degree of market responsiveness through cost sharing, through efforts to, like mandates, to create desired outcomes with supposedly less government. The ACA, in many respects, is the achievement of the old conservative ideal. Effectively, along with the Medicaid expansion, which by the time it passes is a 50-year-old program. So not exactly, very important, in many ways, the most successful part of the ACA, but not something new and innovative. And then in terms of the creation of the individual markets, this was essentially a new regulatory system, but one that was designed to bring patients to private insurance companies. The ACA was many things, but socialized medicine, it was not. Right. It was really the triumph of the conservative approach to healthcare reform.
Yeah. I think what's really distinctive about the United States, at least in cross-national perspective, is that we approach healthcare from the standpoint of three propositions. The first one is Well, we don't really accept healthcare as a right. We say healthcare, well, everybody wants healthcare. It's a set of very valuable goods and services. Therefore, the thing to do is, first of all, try to get as much mileage for coverage out of the private sector and the voluntary sector as you possibly can. And BlueCross and BlueShield, which were basically invented by providers in the 1930s, were an example of that. Secondly, okay, you get as much mileage as you can out of the private and voluntary, as non-governmental, non-public sources, and you admit government into the picture only if and only if gaps remain and have to be filled. And you can identify groups that are both unable to get private coverage and somehow deserving of public coverage. That led to Medicare and Medicaid. And then the third proposition is, well, insofar as you have, say, 15% of your population still without coverage, well, you leave that to the community. We have a safety net, and all those conservative statements to the effect, well, nobody goes without health care in America. If you don't have coverage and you're sick, you just go to the emergency room, and you will get care. So we're a great society after all. And I think the ACA is continuous with that. That is, you build on the private sector, you don't dismantle it. You expand the gap-filling role of government, particularly through the Medicaid expansion, but also the subsidies for use in the exchanges. And you try, insofar as possible, to limit the number of people without coverage, which it's a big success, but it's not a complete success. And I would just add, I think, two things that are important about the ACA. One is, people learned the lessons of the Clinton failure. When you look at how they put together the ACA, they went back and looked at what Clinton had proposed in 93 to 94. As well, an employer mandate, that's probably not going to work terribly well. Emphasizing system reorganization through managed competition, managed care scares the middle class. Tell everybody we're not going to do that. You can keep your provider, you can keep your plan, et cetera, et cetera. And then the other thing was that they figured out how to do this pretty well in Massachusetts, of all things, which I think we may talk a little later possibly about the role of states. But you had, in the late 80s and early 90s, a lot of state efforts at reform, which didn't end well, which kind of petered out for various reasons. And then in 2006, Massachusetts kind of pulled it together and came up with what I would think is a kind of template for the ACA. So I think we did about as well as we are politically capable of doing with the ACA. But Stephanie, I'm sure you have many thoughts about it too, Stephanie.
Thoughts about the sort of the history of health policy. I think I'm not really a policy expert. I think I come at this from the perspective of a clinician. And so my commentary would be on how, the programs that are in place right now, how they enable patient access and availability of appropriate health care. I think that's definitely a step forward from where we might have been in the past.
Right.
So something that is often discussed as part of this discussion of health policy is a comparison of our country to other countries, particularly other developed countries. So just sort of looking at where we are versus other nations, why did our system develop the way it did with its mix of private and public structures, and other countries developed in such a different way?
Shot. Yeah. My core answer is essentially the nature of historical timing and sequence. That in the United States, and Larry touched on this, FDR and his team considered including some form of national health insurance in the Social Security Act. They decided not to do that because it was just too big a lift politically. They were afraid they'd sink the whole bill. They hoped to come back to it later. Mm-hmm. That meant that you got, through Social Security old age assistance, you had a retirement system, a public component of a retirement system established. As you move into World War II, what happens is that public retirement system develops in tandem with private corporate pensions. And there are a whole set of tax reasons as to why that happens in terms of the way Social Security can be counted as a base for corporate pensions to qualify for federal tax exemptions. But that gets established. Social Security is reinforced with private structures, but without any healthcare component. At the same time, you have wage freezes during the war to control inflation, strong union movements, a tripartite system of government, unions, and business working together, supposedly, to win the war. But they can't bargain over wages. One thing they can bargain over is benefits. One of those, of course, are these pensions that I just mentioned. Another is health insurance, which is now a concept that's emerging because of groups like BlueCross and then BlueShield, which had come on the scene, BlueCross in the late 20s, BlueShield about a decade later. So this private model of health insurance is out there.
Well, that was the origin of employer-based health insurance.
Right, that's the establishment of employer-based health insurance. It gets established and rapidly takes off after World War II. So this is an idea that political scientists refer to as path dependence. You have a moment where two options are available, but once you go down one road, it's very hard to get back to the other path. And that, I think, is really the core of what happened in the United States, that health insurance went in a private, employment-based direction, whereas retirement and pensions went in this mixed public-private system for good and bad. There are obviously problems, particularly on the private side of our retirement systems today, but basic structures of the American social insurance system evolved in ways that did not incorporate health insurance on the public side. It's been, we're at now 80 years of efforts to re-engineer that, and we still haven't really completely gotten it done.
I'll just add a kind of footnote. I think there are cultural forces at work, too, that support the path dependence that Guian was talking about. One is other countries are pretty unanimous that healthcare is some kind of right. That, if I'm a citizen of whatever, Denmark, and I know that some other resident or citizen of that country could not get healthcare for financial reasons or for any reason unrelated to their need for health care, that's a kind of moral blemish on the society. And they take that very seriously. If you ask people in polls, sometimes they'll say, well, everybody should have health care. Yeah, it's a right. And then you pursue it and say, okay, in that case, then you're okay with the government organizing a system that will assure that right for everybody, and you may have to pay more taxes, and suddenly the support begins to drop very rapidly. We just don't buy that notion. Secondly, other countries assume that the essence of social justice and equity is redistribution. The reason you have national health insurance is so that sicker and poorer and less well-off people can get care underwritten by subsidies from better off, healthier, employed people, and so forth. That's contentious in the U.S. In the U.S., government-structured redistribution is always a source of conflict. And there's this notion you sometimes hear, I'm a good risk, I run marathons or whatever, I should have a good rate. Okay, so why should I be cross-subsidizing a less desirable population from an actuarial standpoint? Not everybody adheres to that view, but there's enough of it that it really stymies European-style systems. And the third difference is, if you talk to Europeans, and this would include providers and insurers and everybody, they have a sense of kind of collective ownership of the system. This is our system. I get sick, that system takes care of me. Therefore, I, in some measure, ought to be taking care of it by not utilizing care inappropriately. I was in Germany doing some interviews for a research project in May, and I was amazed. You talk to the sickness fund leaders of the health insurance organizations and the providers, the physicians too, and they would say, look, we have to work together. We have to strike compromise. One of them actually said, compromise is in our veins. We have this long tradition of working together because that's our system, and we're responsible for making it work. You don't get that in the United States, where it's much more every interest for itself.
Yeah. It's more of an individualistic society, I think.
Yeah.
Yeah.
So when we look at the other nations compared to the U.S., there's some key indicators we can look at. So infant mortality in the U.S., we rank 45th in the world. Life expectancy, we rank 31st. But we are at the top of spending per capita. So we're at about $9,400 per person, whereas Canada spends about $5,400 and the EU spends about $3,600. So these aren't great outcome comparators, right? So we've talked about how we evolved versus other Western nations, and cultural implications and societal issues, and just sort of the history. But looking at these outcome indicators, what does that tell you about our system? Is it a reflection on our system, or is it sort of just something that goes hand in hand with the way it's developed?
Well, I mean, it definitely says that the increased cost is not proportionate to the outcome on those indicators that we see reported from various organizations. I think another thing that we don't really see when those absolute numbers, like the fact, looking at infant mortality, where 5.6 or 9% of children born in the U.S. die before they reach 1 year of age, is that that's not across the population. There are some subsegments of the population for various reasons where those rates are significantly higher. And I think that's a problem as well. There are people who live in underserved areas who might fall into a certain population group or other, who might be low income, et cetera, or not have access to health care, where their numbers are significantly worse. And when people, from my perspective, when you don't get appropriate health care, when you don't get preventive care, when you don't go to see the doctor when you need to, when you can't manage your chronic diseases, ultimately, when you do finally go, the cost will be higher because you haven't mitigated, you haven't prevented illness, you haven't treated illness early, et cetera. And I think that's definitely a contributing factor.
Yeah, I think you have to be careful with these statistics. Are you talking about the medical system, the health system, or the social system, or some combination of those? Right. Because, for example, one of the reasons for those statistics, as was just indicated, you got a lot of people who have lacked insurance and are only just acquiring it under the Affordable Care Act, who still don't have it, or who don't have good access. And you can have Medicaid, but it depends partly on how states organize the payment system. And well, is the mother carrying that child, is she getting the timely trimestral visits and all the rest? Or I remember once interviewing a head of a medical society, I think in South Carolina, and he said with some bitterness, he said, yeah, Medicaid, it's a great entitlement. We give them a card and they're entitled to call and call and call and try to make an appointment. And that shows up in those statistics. And as a consequence of the lack of timely care, yes, the costs of those births and mortalities are much higher. Mm-hmm. That's part of it. So that's not the medical system per se. That's the health care system more broadly, making it difficult to access the medical system. But then the larger social context matters. I mean, a person can have reasonably good health care coverage, but if they're very low income and they're wondering whether they're going to be able to pay the rent and stay in their house or apartment from day to day, whether they'll be able to keep the electricity on, feed their kids, whether whether they're subject to great stress and violence, all these kinds of things. That is not good for people's health, and that shows up too in longevity statistics, homicides and violence and things of that nature. That's captured at very high rates in the U.S. in those life expectancy statistics, and it shows up in the infant mortality statistics too. So to my way of thinking, you start with the healthcare system and coverage issues, and public health and preventive interventions. You talk then about the social system, and then you try to decide how much of it really is the medical care system, which I think is less culpable for those statistics than is often alleged.
Right, well, there's an expression that we hear, I've heard several times used, is that your zip code is more predictive of your health status than your genetic code, which means where you actually live. And you can look in this city in particular and where people live and have their families and see a significant difference in life expectancy depending on what part of Chicago you live in. So there are obviously a whole range of multiple different contributors to why that happens, but it's an important issue, and I think it really contributes to the kind of problems that we see with the U.S. not having as good outcomes as other industrialized countries.
I would pull some of these threads together a little bit, actually. I agree with both of my colleagues up here. Beginning in the 1940s, the United States made a decision, really even earlier than that, to invest very heavily in our formal healthcare system, particularly large hospitals, or not even large hospitals, hospitals in every community. And there's some real benefits to that. Some of our high-end care, cancer outcomes and things like that, are as good, or in many cases better than other countries. But it doesn't do a whole lot for the kid, 3 zip codes over, who doesn't have enough to eat or has lead paint in their house, the fact that there's a great hospital downtown. And then to bring that, and the other thing about hospitals is they're very expensive. They have been for a long time, and they're one of the driving factors in our excess costs today, one of the key driving factors. And comparing the United States to other countries with lower costs and better outcomes on some of these social indicators, a key difference is that almost every one of those other industrialized countries has some form of price control. In some form, they place limits on what is paid to providers, to hospitals and to physicians in particular. It takes there are different strategies to do that. Some are more negotiated, some are more top-down, but they all do it. One of the defining factors in the United States, and in particular in terms of our excess costs, is that that providers in the United States have a huge degree of control over prices. There's a famous article, about 10 years ago by Uwe Reinhardt, a number of other economists, and the title is "It's the Price is Stupid." And that's really one of the key points to take away in terms of our healthcare system, is exactly that doctors, hospitals simply are able to exert more control over what they are paid than any other industrialized country in the world. I think without exception.
I think without exception.
Yeah.
You're right.
So just to take that further, within our culture, within our values, will we see those price controls in this country?
Go ahead.
One thing, just a point. I think that when patients or people receiving care become more aware of what the prices are, and they have more of a choice, I think that prices will or sort of organically adjust to it, because if they would select a service at a lower price facility, because perhaps their copay is lower, and then this catches on, and individuals realize that they have actually control over what comes out of their pockets, and I think that this will help. So I think more price transparency will help.
I think that's interesting. I had to purchase an MRI for my daughter a couple of years ago, and I, through my health plan, was able to price that. And I found a range of prices literally from $400 to $10,000 within my zip code, within 10 miles. So that transparency is very helpful, right? And not always available.
Right.
Could be. I mean, remember, Medicare pays less than commercial insurance. At present, Medicaid pays less than Medicare, notwithstanding which we do pay more in aggregate than any other country. So those developments within the commercial sector are terribly important, and it may indeed be that, there's this argument that people have more skin in the game and more information to go along with it, they will make more cost-conscious decisions, and that may turn out to be the case. How dramatically that would reduce our healthcare spending is an interesting question, because a lot of that spending is sort of non-discretionary. That's what happens when you're seriously sick and you're in the hospital and you don't have a great deal of choice over the things that are being done to prolong or save your life. But that is one thing we will see.
So since the election in November of 2016, we've spent a lot of time, a lot of political time, trying to dismantle the ACA, either wholesale or by piece. So progressive reform at this point seems like something that's not going to happen in Washington. But should we be looking to the states? So what role do the states have in moving a lot of these objectives forward?
I think they can have a significant role. One is sort of a larger political reason is in that Americans tend to be more receptive to state government action than federal. It's a very broad and not always consistent principle. Generally, there may be more options there. A couple of possibilities that are out there. We've seen Medicaid expansion in, what are we up to, 32 states. And one possible route towards greater coverage is making those programs more generous, more expansive, and additional states moving to expand Medicaid. It's conceivable, and I'm not sure you can get there in every red state, but that you could have a Medicaid for all kind of a program in the United States, where you would have variation by states with some broad federal baselines, but more capacity for states to choose the approach they wanted. I'll highlight another more obscure area. Back in the 70s, there was a strong move to state-based rate regulation for hospitals. At the peak, I think there were about 30 states that in one form or another regulated hospital rates. With the push towards deregulation in the 80s and 90s, every state except one, Maryland, ended their rate regulation program. And here's the kicker on the sort of markets and deregulation story. Maryland has been much more effective at containing the growth of hospital costs than every other state. So, a back to the future option. I've talked about the whole issue of cost. I'm all for price transparency, but if we were to look at a more aggressive model, one way to go about it that can be very locally sensitive or more sensitive to local and regional conditions is for the states to move back into that area. To consider building on Maryland's model. There's some interesting experiments in expanding the Maryland model going on right now. They have an additional waiver from the Center for Medicare and Medicaid Services, where they're not only setting the rates of hospitals, but they're actually doing a global hospital budgeting or cap, essentially, on hospital revenues annually. And the interesting thing, Larry and I were talking about this earlier, is that the hospitals in Maryland actually go along with this. It's a system that's regularized their environment, and I think it can be a tough lift to move to that kind of a system, but I think there's actually a lot of potential there.
I think there's two aspects here. One is, are the states innovative? And secondly, do the innovations diffuse? The states can be pretty innovative, and Guian just gave a very good example of rate setting in Maryland. And I mentioned before, Massachusetts in 2006 basically created the template for the ACA. The trouble is that those innovations don't diffuse very easily. You got a lot of one-off states that are able to put something together because of political and cultural and historical factors that are distinctive to those particular states. So the diffusion part is hard. But I think, this is going to be very interesting. November 6th this year, you mentioned the election of 2016. Well, the midterms are going to be very important because if the blue wave materializes, that's going to have an impact not just on federal policy, but state policy. One of the facts of political life over the last few years and since the Tea Party days is the Republicans, and particularly far-right Republicans, have done a vastly better job of mobilizing to contest governorships in state legislatures than the Democrats have. And the Democrats basically kind of let it slide while assisted by money from the Koch brothers and other very wealthy conservative billionaires. The Republicans put together a terrific organization to capture state legislatures and governorships. That could change on November 6th. If that happens, you watch those 18 states that you just mentioned that haven't expanded Medicaid. I bet you a number of them will move to do so. In Florida, for example, the governor said, well, we really should expand Medicaid. There was strong sentiment in parts of the legislature. But the Republican Speaker of the House in Florida was mortally afraid that if he went along with that, somebody to the right of him would come along and primary him, that is, knock him off in the primaries for reelection, and that has paralyzed Medicaid expansion. So you could see, depending on how things turn out, you might see a real renaissance of state innovation in healthcare, starting with Medicaid, but expanding beyond it, maybe even to rate setting, as you were just describing in Maryland. So stay tuned, you know.
So you bring up a really important point that there's, you know, it's blue versus red on these issues. But one of you mentioned that the Affordable Care Act is sort of a conservative success, even though the conservatives are so opposed to it. So why is there such a partisan divide on these issues?
Where to begin? Well, you pointed out, Guian, that the individual mandate, I think, originated with the Heritage Foundation around 1987, Stuart Butler, right. And then remember that was part of the Massachusetts packet. Romney, Mitt Romney, then Governor Romney of Massachusetts, this is a great idea. So it's common sense. It's individual responsibility. If I want to ride around on my motorcycle and get into accidents and go to the emergency room, it's just socially irresponsible of me to then say, okay, I won't have coverage and let somebody else pay for it. He made eloquent and very sincere speeches about it. But as soon as he became Republican candidate, you know, the Cato Institute and other conservative organizations all turned on that notion. As soon as it became an element in the Democratic agenda in these times of fierce partisanship, oh no, and Romney was reduced to saying, oh, well, individual mandate, that might make sense for a single state, but not for the whole country and things like that. So with the Tea Party dynamics that set in the summer of 2009, everything became so polarized that what was formerly at least discussable in conservative circles became toxic. And we haven't broken that yet. Again, we might.
I agree with all of that. I'll add, I think, some more maybe elemental factors. My view is one of the more powerful driving forces in human motivation is fear of losing what you have.
Yep.
And for Americans who have employer-based insurance, even if it's getting more expensive and more co-pays and deductibles and covering less, there's the fear of the unknown. And I think that's been a very powerful, particularly in recent years, that's been very powerful. The sense of, as we touched on earlier, not having a sense of the common, particularly in a country that still has the racial divisions that we do and ethnic divisions. I think that's a very powerful factor in explaining the reluctance to embrace this broader sense of the good and the good for our fellow citizens. I think we have to go to some of these deep fault lines in American history that sadly are not so historical. They're very much with us today.
Right. So going forward, there's a lot of candidates, some senators now saying we should have universal health care and pushing that forward. Is this something reasonable to pursue at this time? Or would it be better to sort of shore up the ACA?
Yes, want to go first?
I go, okay. I don't know. What I said before about is healthcare or right, you get a kind of a dynamic around this kind of issue, single payer, Medicare for all. And this is what I'm saying, may be controversial, but you just present the notion in general, and you get a lot of support. Yeah, that makes sense. Then whether say it's a referendum in a state or just conservative opposition blasting away on the airwaves. Okay, how much is that going to cost in taxes? And Teddy Kennedy always used to say, all right, well, look, what's the difference? A dollar's a dollar, whether it's an insurance premium or it's a tax dollar. And if you end up actually, spending less overall when it becomes a tax dollar instead of a premium dollar, aren't you better off? Nobody, culturally, it doesn't fly, that notion of raising taxes. Then, okay, government, if it's funding it, it's going to ration care. I have to say, government take over the healthcare system. A certain significant fraction of the population will say, yeah, that's right, that's just no good. I'm going to lose my choice of provider, my choice of plan. I'm going to lose my familiar employer coverage. Quite possibly, the devil is very much in the details, and the details tend to erode support for single payer and I think Medicare for all. I think it's dangerous. If it was me, I would say try to build on the accomplishments of the ACA and Medicaid for more. And you mentioned quite rightly the possibility of a Medicaid buy-in, which I think has been discussed at intervals in both Hawaii and Nevada, though I may have my facts wrong. That's what I would do. I think the other is too vulnerable, but that's just one amateur reading of the political tea leaves. I'd be interested what my colleagues think.
Yeah, I can't really comment on why this is the way it is. But I do know, and I do agree with Dr. McKee that people do have a tendency not to like change. They'll be afraid of change. How is it going to impact me? And that the perspective of what is for the better good is not always one that's espoused, and I think it tends to slow things down when we're trying to make progress in a variety of areas, including healthcare.
I share a lot of Larry's concerns, maybe all of them, particularly on the cost. It's going to be intensely expensive. That said, the politics of this are absolutely fascinating right now, because I don't know if it's going to be possible to win the Democratic nomination in 2020 without embracing that idea. I mean, we'll see how it plays out in the primaries, but that is very much the way, at least one possible trajectory. I do think there's some possible middle roads, though, that might eventually gain traction. Along with the Medicaid buy-in, there's the possibilities of expanding Medicare in part. You can do a couple of things. There's a the terms of ours, Medicare for the middle-aged, where you basically lower the eligibility age to 55 or even 50. Heck, you could go lower than that if you wanted. I particularly like this because it has this wonderful actuarial effect that if you put people in their 50s and early 60s into the Medicare pool, their average health costs are lower than the existing Medicare pool. So your average Medicare costs actually go down. Mm-hmm. At the same time, their costs are higher than the average pool in the individual markets on the insurance exchanges. So you're pulling these relatively higher cost people out of those pools. Premiums for younger people actually go down. So there's a win-win on both sides of this. There are other things you can do. There's a Medicare X proposal that essentially puts a Medicare option onto the exchanges. There are a couple different versions of this, but you add it into different components of the system. So Medicare expansion may be a lot more viable politically than the heavy lift of going to true Medicare for all, whatever that exactly would mean, and there are different models of it. One other quick baseline, to talk about any of these things, you're really talking about the Democrats having control of the White House and Congress, or some kind of a change in the makeup of the Republican Party that you could find people willing to agree to some compromise. And it's not an easy road.
So let's shift our attention a little bit to more granular aspects of policy. There's been a lot of discussion of value-based care. So could we talk about what it is and how it differs from traditional models?
I can talk a little bit about value-based care. Value-based care is really a method of reimbursing for care that focuses less on payment for volume and more on payment for value. So ultimately, the goal is to manage costs while ensuring that the care provided to patients is of better quality. There are a number of models out there for value-based care. You've probably heard ACO, which is more like a combination of care providers, hospitals, et cetera, all under the same sort of cost structure, intensive medical home, episode-based payments, et cetera. But these all follow the similar philosophy as paying for value or paying for quality.
So when we talk about adding value-based care or focusing on that, it will oblige healthcare systems to do more population health management. Is that something that the systems are ready to do?
I think we've already, systems, I mean, I think that population health, the term population health has been around forever, it's in the public health parlance. I think, you know, there is a movement towards population health that ties into the need or to look at the individual in a more broader sense when we're talking about how to make people well, how to provide you know, appropriate care longitudinally. So this is starting to be embedded in a lot of structures, the whole concept of population health.
I just said, I think it's absolutely, as somebody who's taught in the School of Public Health for a long time, and as you rightly say, the notion's been around a long time, we all say, finally we're getting, you know, we're getting into prime time, and the notion of population health management is what we should have been doing all along. But you look at the practicalities of it, it can be very complicated depending on who's doing it how. For example, when the ACA came along and imposed penalties on hospitals that had excessive rates of readmission to hospital in Medicare after 30 days, that really caught the attention of some of the big centers in New York and elsewhere. I look at the ones in New York where I live and work. And before, you know, okay, somebody comes back in and is readmitted. It's a source of revenue. So fine, it's unfortunate. We'll worry about it some other time. When it ceases to be a source of revenue and becomes a penalty, suddenly, great attention. Who are these people? Why do they keep coming back? What's wrong with them? And you come to realize that mental health services are inadequate for them in many cases. There's substance abuse, and they're ill-housed, sometimes homeless, a whole range of considerations that are in many ways more social than clinical. So they say, okay, we're going to do population health management. We, the academic medical centers, the health systems, we got to figure out how to get these services to these people in a timely and effective fashion. Well, then you have these big kind of, we're talking about, say, Johns Hopkins, these hugely complicated, specialized, in many ways introverted healthcare systems reaching out sort of willy-nilly to community-based organizations, which are very, very different. Some of them are, and they're highly diverse, but some of them have limited staffing, limited information technology, limited ability to do documentation. They have a different constituency from the community, from that of the hospital system. And there's a real sometimes dialogue of the deaf and much frustration as they try, as the health systems try to figure out how do you cement contractual relations and not least important, just build trust and communication with these very different kinds of service providers, mental health services, substance abuse services, nutrition services, housing services, employment services, and sometimes the law enforcement community. All of that, it's really quite difficult. There's a program, federal program, district delivery system reform improvement, some program or something like that. I don't know if, I have a feeling Illinois might have that, but I'm not sure. New York does. And they gave the money to places like New York Presbyterian and Mount Sinai. And they said, okay, you guys go out there and figure out what you're supposed to do in the next 5 years, bring down unnecessary spending in Medicaid by 25% by avoiding unnecessary hospitalizations. And by and large, it appears that the academic centers have done what you would expect they do. They appoint a new assistant dean for district affairs and remodel an office and acquire some more computers and gear up for it. And the money doesn't go out the door to the community-based organizations. And even when it does, they feel condescended to, they feel resentful. The academic centers think these guys are clueless, and it's a practical challenge that hasn't been sufficiently attended to in interorganizational terms. But maybe we'll get there, I don't know.
To put a specific example on Larry just said. I'm doing some writing about a case at Hopkins in Baltimore where in the late 60s, in the aftermath of the uprisings after the King assassination, which came more or less right up to Hopkins gates, Hopkins did exactly this kind of a project, setting up a community health program with a community development organization in the area. And to make a long story short, by 1985, they'd converted it into an HMO, run completely by Hopkins with basically no community involvement. So we've got to pay attention to our history of what can go wrong. The other point I'd make is that we actually do have a fairly extensive network, vastly underfunded, of community health centers around the country that go back to the war on poverty. I guess some of them you can even trace back to Shepherd Towner, to maternal infant health programs in the 20s. So we actually do have a significant, if really underdeveloped, infrastructure that may be more promising for that kind of work than the big academic medical centers, or even maybe some of the community hospitals.
Absolutely.
Just a comment. When the community health centers were in their heyday, were they effective?
It depended, it varied greatly. I've done a fair amount of work on the war on poverty, and that's the answer to everything with the war on poverty, is it entirely depended on local conditions. The idea that the war on poverty failed, often a real tangent here, is not really accurate because it was so localized in its implementation.
That's right.
And it depended on funding levels, who's running it, what the goals are, population characteristics. One thing I'm struck by is the persistence of those centers, though, that what they deliver, they may not be delivering everything that we'd like them to be, but many of them do a lot of good work in the areas of their chosen mission. But they may not be robust enough in their current form to tackle some of these
That's a great point.
goals.
So we're coming close to the end of our time. Before we turn it over to audience questions, I want to ask each of you, what is one thing you wish the public understood about the healthcare system and healthcare reform?
I would say that it is extraordinarily complex. And
Who knew?
yeah, I think as everyone has heard, it's very, very complex and multi-layered and really, I think in order to move to a sort of a desired endpoint, it really would take cooperation and amongst a variety of organizations and stakeholders to really make a material move in where we are. But at the same time, I think it's promising. I think we've seen positive movement. I think we've seen expanded access. I think we've seen some slowing of the cost rate of increase in the country. So there's some positive movement, but I do think that it will take a lot of cooperation and collaboration to work very effectively.
I think my point would be a related one, and that's, I guess I'm really speaking more to my progressive friends, that we can't just focus on the insurance system, on the financing. We have to focus on the system of provision, as I said earlier, on doctors and hospitals. I'm not just saying this because I've got someone from BlueCross here. I think this is a really important point. In terms of understanding cost and outcomes, it's not enough to just go to single payer. We're going to have to deal with some of these underlying dynamics in the nature of healthcare markets in the United States to get a sustainable solution over time.
And I'll build on that and say not only do we have to worry about the broader issues of healthcare markets and not just single payer, we have to worry about the interface and the interplay between what I said before, the healthcare system, the medical system, and the social system. We mustn't lose sight of the social determinants of health, the way in which non-medical issues of income support and stress and safety and employment and education, very importantly, and mental health services, that kind of thing. There's a whole range of health, the whole range of variables that very much affect people's healthcare outcomes that cannot be addressed solely or mainly through the healthcare system or the medical care system. So we have to think more broadly and a bit outside our comfortable niches as healthcare professionals, whether it's medical professionals or public health professionals or whatever piece of the elephant we touch.
So I'd now like to open it up to members of the audience. Please, I believe there's microphones available. So when you have a microphone, you're welcome to ask the panelists a question.
Well, I have both a question and a couple of comments. I'm not someone who studies this or someone who's an academic like you people are, but I've been alive for 71 years and I've dealt with insurance and healthcare. And one of the things that you didn't mention that I seem to remember is back when I was young and I had BlueCross coverage, BlueCross was a nonprofit organization, as were most other health insurance companies. And there was a time, and I believe it was during the Reagan administration, that all changed, and insurance companies were allowed to become profit-making, and now we have, you know, CEOs of insurance companies making $30 million a year or whatever, and spending money on buildings because they have too much money to report as income, and they spend it on things that are not health care, you know? So that's one question about the cost of our care in this country, because we have to make room for the private profit. The other thing that I just want to comment on is it seems to me whenever I see some group that's organized, whether it's under a government auspice or a congressional committee or some, you know, private group like the Cato Institute or whatever, they put together a bunch of people who are academics, people who administer or study healthcare, but they never seem to have anyone on those panels that deal with it day to day on the front lines, delivering healthcare and you know, having to deal with these systems on a day-to-day basis.
Yeah. Well, if you're a true believer in market forces, you know, you just know that you're right. What's the point of trying to wrestle with the complexities of actual clinical realities or running a hospital or anything like that? You just want to, you know, you want to just pull out Adam Smith from the bookshelf, and that'll tell you what to do. And that goes also to the first part of your question. You're right. In the Reagan years, but starting in the early Nixon years, there came to be this view that, you know, market forces is the answer. And what we really need is correct consumer incentives and choice and competition and all that kind of stuff. And we'll figure out how to do that. And that coincided with the realization, I think, in the investment community, Wall Street and investment firms, that healthcare spending keeps going up. We don't really know how to get a handle on it. And if you can get in on the ground floor of investing in something like HMOs that will be able to purportedly at least cut the cost, you can make a great deal of money. So what you say is true. Somewhere around 1985, middle Reagan years, the HMO movement, so-called, which had morphed into a not-for-profit kind of sector of plans, went for profit very, very rapidly. When I first looked at HMOs in the late 70s, I would interview people, and they would say, well, we have to be nonprofit because if you talk to the equity investors, they don't think there's enough return on investment. That changed, and when that changed, and equity investors got in big time, not only in HMOs, but in BlueCross and insurance companies and the rest, there's no stopping it. And so everything we've done subsequently has entrenched for-profit insurance more deeply in our system. That includes Medicare Part C. Now 1/3 of Medicare beneficiaries are in private plans, mostly for-profit. That includes Part D for drug coverage. That is explicitly designed to be marketed through private, mainly for-profit plans. And that includes the health exchanges, which are mainly run by for-profit insurance plans. That includes Medicaid managed care as well. So we have basically handed the system over to for-profit insurance in the name of some kind of, you know, that's what produces efficiency. It certainly does produce profits for shareholders. Whether it produces the kind of healthcare system we want is another question altogether.
Really quickly, I have a slightly amusing story about your point on Blue Cross and its nonprofit status. I wrote an op-ed earlier this year. It's about the time Amazon was making it, well, they're going into healthcare, about the time that was announced. And in the op-ed, I made exactly that point about Blue Cross shifting away from nonprofits. And I got, or actually the editor, the publication, got a very angry email from Blue Cross saying, no, we're still nonprofits. We demand a retraction. We demand that you change this. And my response was, okay, there are two ways we can do this. We can slightly change the language to technically nonprofit or something, or I can write a whole paragraph about the various lawsuits on exactly that issue and the points you made. I don't mean to bust on Blue Cross in particular, because it's true of many of the academic medical centers that we've talked about as well, that are nominally not-for-profit. By the way, I always say not-for-profit rather than non-profit, if you catch the distinction there. They may not be for-profit, but it doesn't mean that they aren't doing quite well. About 7% over costs in the larger AMCs right now. And yeah, it's a huge issue, and there's a whole history of nonprofit attempts in the American healthcare system. It is one of those other bigger structural options that in an ideal world we could think about resurrecting. I think the ACA even tried in a kind of weak way. It didn't go very far.
Co-ops, the consumer-oriented and operated healthcare plans, which were once, I think there are 26 of them, and now approximately 3. And partly because it'd be very complicated to go into all the reasons, but they couldn't, they were kind of tossed out to sink or swim in a larger world of for-profit insurance, and they were not equipped to swim.
I was just wondering how, when it comes to doctors setting their rates, how does malpractice insurance cost factor into that? Because I have several friends who are doctors, and based on what they tell me, that is a huge burden on them to recoup the cost before they even make a penny when it comes to setting their rates.
I think the malpractice insurance that physicians have is separate from the rate setting.
They would have to cover it in their overall.
Right. Mm-hmm.
I am not by any means an expert on malpractice insurance. My understanding is that it's a significant cost for physicians, and particularly in private practice. Its actual share in overall healthcare costs is relatively minor. That it's one among many variables, but it's not not the driving force of excess cost in the United States. Which is not to say it's not a huge headache and a huge source of stress for individual physicians. It is.
Yeah, I'm not an expert at it either, but I think it varies a good bit with medical specialty. I guess OBGYNs face particularly severe burdens. And again, the cost of malpractice settlements, that is, resolving actual litigation, is not all that great. It's about 2% of our healthcare budget, I think, from the studies that I've looked at. But the cost of defensive medicine is much more diffuse, and in the nature of the case, hard to measure, because you just don't know. I mean, physicians who are doing more tests for fear that if anything, they don't do them and anything goes wrong, they'll be sued. That's a serious thing, but it's very hard to know how to quantify it. It varies a lot.
So most of the public discourse nationally is about more comprehensive health reform, whether it's Medicare for all or the American Healthcare Act that the Republicans put forward. Is it harmful to focus on more comprehensive reform, the all or nothing, rather than increasing subsidies on the exchanges, fully funding risk corridor programs, the public option, like those incremental approaches? Is it harmful to focus on the more comprehensive approach rather than the slowly move the ball down the field type healthcare reform?
if I'd say that it's harmful. I think it's really a question of objectives. I'll be honest, we talked a little bit about why there's such partisan division. Beyond just the desire to defeat Obama, I've been a little puzzled by the Republican response to the ACA in kind of a big context. And I understand it's a great issue to mobilize their base from, during the Obama years. But I think back to the degree to which, a historical example, through the 70s, the 80s, the early 90s, welfare was a huge cudgel that the Republicans used to beat the Democrats with. And in 1996, Bill Clinton signed welfare reform. Now, we could have a whole session on, is that a good thing, a bad thing? What are the consequences of it? I fall on the side, overall, not a great thing. But it had an effect for the Democrats that for a while, and it's come back a little bit under Trump, it took that cudgel away from the Republicans. They really, you think about how much did you hear about welfare reform in 2000 or 2004 or 2008. It just wasn't the salient issue that it had been in the previous decades. If the Republicans had taken a different tact after the ACA, or even during the ACA, and worked to strengthen the ACA structure, which, as I said at the beginning, is a fundamentally, I argue, conservative structure, they would have done the same thing to the Democrats, that this will be one of the core issues that Democrats run on this fall, in 2020, and however long it takes to resolve the problems with the current system. So the politics of this are always fascinating, the calculations of short-term versus long-term. I don't know if I answered your question, but it's where it led me.
Well, compare, on the one hand, okay, Democrats should run on single-payer Medicare for all as a comprehensive change, even a litmus test. Or Democrats should run on keep making sure that the protections for people with pre-existing conditions must not be violated, which the Republicans are trying to do in all sorts of ways. The former is comprehensive. The second, I suppose you say, would be incremental. My guess would be the second is going to be more productive politically. I think it'll resonate more with people. Comprehensive can scare people off. I remember the thing about the Clinton plan, the great virtue of that in the eyes of the people that produced that plan was it was comprehensive. We know the system is broken. We know the system has many different parts. We know that you don't want to squeeze a balloon here, then it'll pop there unless you do everything in a systems analytic way. And so they produced that and scared the population. The voters and everybody else looked at that and said, that's going to radically change how I access healthcare, how I'm covered, my whole way of interfacing with the healthcare system will change, and it was a disaster. Again, universal coverage is, I think, genuinely a moral imperative, but then the question turns to, okay, what is the tax implications, and was it a government takeover, and what will government be telling us we have to do and can't do this? Incrementalism, I think, on the whole works better, but it's a tricky term. Like, for example, you take Medicare in 1965. Was that incremental? I mean, compared to what we had before, it was a big breakthrough. Compared to national health insurance, universal coverage, it's incremental. So it depends partly on your definitions, but I think unless you have, and you said this very well before, you'd have to have a Democratic president with solid majorities in both the House and Senate. I think incremental is probably the way to go. But it's also possible that, building support for comprehensive proposals is a way of building the kind of support you can then draw upon for incremental achievements. It's a good question.
In the front here.
Hi, I'm going to try to sneak in two questions. They say it's a lot harder to start something new than to take something old away. Do you think the ACA is one of these old things that's already hard to take away, or it's something that's in serious danger of being lost? And then my second question is mainly for Dr. Stephanie. As a clinician, with the complexities of our insurance system, do you feel that there are people with insurance who aren't receiving the health care that they could because of confusion over the system? And if so, how does that manifest?
I can take, let me take your second question to start with. Yeah, I would agree that healthcare can be very complicated for people. And I think it's important for individuals to try to understand what their health insurance means and to understand their health insurance benefits so that they can maximize their use of the benefit that's available to them. And there are various ways you can learn about that. Usually a health insurance company will describe that to you on a website, or you can call and ask questions about it. You know, I'm a big believer in health literacy for people to really understand their own health, understand, you know, for example, what kind of preventive care is appropriate for someone your age. You know, I have a medical condition. How do I understand it better? How do I learn about it so I can be a more active participant of the healthcare team, and you know, understand what I can do to maximize my own health. So I think the learning and engagement in the process I think is important, because I think rather than have the system be running the show entirely, I think engaging in it is an important part.
I'll speak to the taking away, starting new things. When the ACA passed, the assumption on both conservatives and liberals was, if it can stay alive for a couple, you know, a few critical years, you'll never be able to undo it. And the view was January 2014 was particularly important, because that's when the Medicaid expansions kicked in. That's when the subsidies on the exchange kicked in and all of that. And when they got past the Supreme Court case of 2012 and got past the re-election of Barack Obama, I think many liberals felt, okay, we're on safe ground. And I guess basically that's true in the sense that we have not repealed or hugely dismantled the ACA. The Medicaid expansion still stands, albeit in 32, not 50 states, the subsidies and so forth and so on. On the other hand, they came with one vote. If it hadn't been for John McCain and his famous thumbs down, it would all be different. You know, I've studied this stuff for like 40 plus years, and I've concluded the more I study the American healthcare system, the less I understand it. And I don't know. You never say never.
We have a question in the front here.
Ma'am?
Thank you. Thank you for sharing your insights with us. I can appreciate the social determinants of health aspect, the path dependence aspect, and the complexities that exist. And I'd like to ask if you could share your insights on two things you touched on, and one more. One being, who defines value in terms of quality? And then the second one, the cost of educating a physician, including the opportunity costs. And then the third, mental health care. Not only the substance use and the opioid epidemic, but particularly from youth to adulthood. And I come from the perspective of being a physician, of being a child psychiatrist and a clinical medical ethicist at an academic medical center. And so these are the struggles that we have day in and day out, especially with the RVUs, or relative value units, productivity requirements, and the moral distress we continually experience. So quality, mental health care, and then the cost of educating a physician. And NYU recently now is doing away with tuition. And so if you have any insights you could share on those, I'd appreciate it.
You know, in terms of what defines value, I mean, you know, I think about evidence-based and what is guideline-based. And, you know, as, you know, if we think about it, you know, historically, you know, healthcare used to be provided sort of, there was no research being done. The care was provided, and sometimes it did good, and sometimes it caused harm. And then the term evidence-based was coined in Canada in about the 1950s, when the process started to develop where research was done to try to determine if a particular course of treatment was effective or ineffective. So when I think about quality, you know, and I have a definition here in my book, but when I think about quality, I think about providing care that's most likely to lead to a positive outcome for the patient, and that where there has been some form of evidence to show that it works. I mean, obviously there are some treatments that have been provided for so many years, and there's anecdotal evidence it works, and so it continues on. So I hope I answered your question about what provides value. What provides value is what works and helps people maximize their health. Now, in terms of you know, issues that we have in this country, we have some really significant public health issues that are going to be, I think, worsening in the future, and we're seeing increases in them. And obviously, I agree that we're in a little bit of a mental health crisis. In particular, I see increases in depression, anxiety in children, which is particularly painful to see. You know, we also see, you know, other healthcare issues arising, the obesity epidemic, all the diseases attached to it. You know, there's just a whole, you know, the aging population, we're seeing more chronic disease. So there are a lot of healthcare issues that are facing us in the future that are going to be really difficult and challenging. And then regarding the cost of medical education, yeah, I read about MIU, and I think that's very refreshing. Medical education, business education, professional education is expensive. I'm not really sure what the answer is to that, though. But it's nice to see what MIU is doing.
One piece that's worth touching on, and I guess this gets into the category of the opportunity costs, is the possibility of increasing the share of care provided by non-physician providers, nurse practitioners, physician assistants, and particularly when we talked about community health centers, that's one way to make the care provided there better, more comprehensive, and deal with some of those population issues. Yeah, I just would second the point on mental health. My state, Virginia, has been struggling terribly with access to mental health care. I think it's typical of around the country. Literally just the number of beds available, the number of providers available. I would extend it out to include access to care and coverage for disability generally, that this really needs to be something that we bring into the language of healthcare reform. There's a great piece by Harold Pollack in the American Prospect a couple months ago that made that argument much more eloquently than I am now, but absolutely.
So we'll take one more question right here in the front.
Hello, my name is Karina Herrera. I'm a senior McNair scholar here at Roosevelt University, and I wanted to thank you all for your time here at this panel. This dialogue has been very educational. I appreciate it. Dr. Brown, I was glad that you mentioned or brought up the socioeconomic factors in that some resources may not matter to someone who does not have access to it, or as you said, someone who's living in a house that has lead paint. Yeah. In terms of what you, Dr. Stephanie, were saying, that patient awareness and transparency may be able to reduce costs or help control costs. I'm wondering if, like, as you said, Dr. Brown, that you've studied it your whole life and it still confuses you. And if we're here as a room of academics still being befuddled by this, how can we then turn around and expect a family who is not sure where their next meal is coming from, or is not an academic specifically studying public health administration for 42 years, to look into costs and understand it and choose wisely? Health literacy matters, but it seems like we're setting an expectancy unreasonably high.
I think that's one piece of a huge puzzle. You know, at the same time, if an individual is ill and doesn't really understand how to take their medicine, you know, what they can do to be part of, I really do truly believe that patients have a right to be part of a healthcare team. They have advisors, you know, their physicians, the nurses, the other practitioners who help them, but that engagement helps overall improve that patient's outcome.
Well, we talk so much about, you know, correct incentives and evidence and transparency and so forth. We don't talk enough about trust, communication, literacy, and just the kind of social interaction that people require. In the public health world, we're really good at saying, oh, go out and eat fruits and vegetables and exercise and so forth, and then we feel our job is done. We've delivered this valuable information without stopping to wrestle with questions about how realistic is it that people are going to be able to do this. And the farther down you go on the socioeconomic scale, the harder it is to comply with those doctor's orders, as it were. We don't spend near enough time thinking that through from the standpoint of the disadvantaged citizen or resident of our country.
Well, the key is to meet the patient where they are. So if the patient has a language barrier, if the patient has social issues, if there are cultural barriers, et cetera, so understanding them and trying to address them is also part of, helping make sure that they really are treated appropriately and that they understand. Right, so I would agree.
So with that, we have to conclude our panel discussion. The panelists will be available for a short time if you want to stay and ask more questions. But at this point, I'd like you to join me in thanking our panelists for the conversation that we've had. And thank you all for joining us today.